Hello friends and colleagues, I am Dr. Colonel Manas Chatterjee. I am Senior Advisor, Professor and Head of the Department of Dermatology at the INHS Ashwini at Mumbai. Today I would be talking on one of the important disease conditions in our practice, that is urticaria and its management. Allergic diseases are common among the general population. Among these, urticaria, and specifically chronic urticaria, is likely to affect up to 20% of the population during their lifetime. Often associated with pruritic wheal and flare reaction, which may be associated with angioedema, it can also cause pain in some patients. Factors triggering the onset of urticaria can be identified in some, but the disease is idiopathic in 50 to 80% of all cases. Through this understanding, our best option to manage this condition is to avoid unidentifiable triggers, but mainly to counter the allergic pathophysiology of urticaria using antihistamines. While all international guidelines recommend non-sedating second-generation antihistamines as first line of treatment for urticaria, it's difficult to select the ideal one, as the commonly prescribed ones lack efficacy, for which we need to add or updose current available antihistamines according to patient profiles. So today I would be talking upon bilastine, which is a new second generation H1 antihistamine with an ideal antihistamine characteristic which is recently launched in India. Bilastine has been approved in more than 100 countries globally and have decentralized approval in 28 European countries, with large extensive clinical data studies conducted on more than 5,000 individuals with more than 22 million patients using bilastine worldwide. Bilastine is considered as a first choice antihistamine among Asian Pacific, that is APAC physicians. ARIA recommends bilastine as the highest scoring antihistamine among all other second generation antihistamines, and this is the only one to achieve a perfect 10 in the antihistamine scorecard. In India, it has been approved for the symptomatic treatment of allergic rhinitis and chronic urticaria in patients older than 12 years of age. Bilastine 20 mg comes in OD dosage, which is effective in managing symptoms considering its quick onset of action than cetirizine and longer duration of action as compared to fexofenadine, which makes it a potentially attractive therapeutic option. Bilastine's effect versus levocetirizine are backed by studies which state its superiority in the percentage of symptom-free patients, response rates, and health-related quality of life. When it comes to efficacy, bilastine has high specificity for the H1 receptors, that is 3 and 6 times higher than for cetirizine and fexofenadine respectively. It has rapid and sustained action with the 8-hour duration of maximum effect and significant activity for at least 24 hours following a single dose, which makes it an ideal choice among other second generation antihistamines. Bilastine is an ideal antihistamine for updosing in difficult to treat urticaria as recommended by the EAACI and Galen and EDF and WHO guidelines for the management of urticaria. Bilastine has a Tmax of 1.13 hours, while the absolute bioavailability is 61%. Its half-life is estimated at 14.53 hours, while the published values for cetirizine and levocetirizine is about 8 to 10 hours. APAC review on the selection of optimal second generation antihistamines for urticaria in Asia has also given its support to bilastine safety. Bilastine's robust clinical assays and studies in healthy volunteers to the actual accumulated clinical experience, bilastine has a profile of adverse effects similar to that of placebo and does not appear to significantly influence cardiac conduction, alertness, or driving ability, even in doses up to 40 milligrams. Bilastine does not prolong the QT-QTC interval and does not cause significant changes on the ECGs at therapeutic and supratherapeutic doses, making it an ideal choice with regard to cardiac safety concerns. Considering bilastine pharmacokinetic profile, it doesn't have any CYP450 mediated drug-drug interactions. It's also not necessary to make dose adjustments in patients over 65 years or in patients with renal or hepatic impairment. Low potential for CNS impairment when co-administered with alcohol and other CNS depressants is another advantage. At therapeutic doses, bilastine does not have anticholinergic effects and does not affect psychomotor performance. Bilastine is a good substrate for PGP, which would limit its passage across the blood-brain barrier into the brain. As it shows a relatively zero brain H1 receptor occupancy rates compared to other antihistamines, incidence of sedation with bilastine is similar to placebo, even at dosage 4 times the approved ones. Studies have shown that it doesn't have any effect on driving ability and flying conditions and has no effect on cognitive impairment as seen with other antihistamines. In fact, during on-road driving test studies with F1 car simulators, bilastine does not show significant differences versus placebo. Even when tested, as I said, in simulated conditions of high-speed driving of an F1 car, operating heavy machinery and in pilots driving, and bilastine does not induce significant sedative effects. An active control arm study comparing hydroxyzine with standard dosage bilastine, which is 20 mg once a day, and higher dosage, which is 40 or even 80 mg, which is 4 times, found no significant effects on various objective measures of psychomotor and driving performance with bilastine at all these dosages. As a clinician, I'd look forward to using bilastine as it checks almost all the boxes for the qualities needed in an almost ideal antihistamine. Bilastine has been acknowledged for use by guidelines such as ARIA, and this is the only one which has achieved perfect 10 in the antihistamine scorecard and has also been scrutinized to become the first choice antihistamine among Asia Pacific, that is APAC physicians.